You're welcome to my channel. Thanks for visiting. Remembering to subscribe, sharing all my presentations, and listening to this very well. Today is all about typhoid treatment. Typhoid treatment. For a full note on typhoid, please kindly click on this very link. This link will take you to a full note on typhoid. Everything you need to know will be right here if you click on this link. But for this very presentation, I will limit myself to the treatment only. Now, the treatment of typhoid. Typhoid could be treated, at least you start empirically. So empirical antibiotics. But first thing first, you must take sample for microscopy, culture, and sensitivity test before loading the patient with our antibiotics. Then you can go ahead with fluoroquinolones, third generation cephalosporins, ampicillin, azithromycin, cotrimazole, or chloramphenicol. However, chloramphenicol has limited usefulness because of the increased rate of drug resistance to chloramphenicol. I'll talk more about that. Now, chloramphenicol. It is pretty cheap, still used in poor communities up till this moment, has limited usefulness, however, because of the increased rate of drug resistance. It may cause aplastic anemia, okay? There is low risk of fatality due to aplastic anemia. Let me explain. Meaning chloramphenicol can lead to aplastic anemia. There will be fatality that could follow that, though it's not so high, it's not so massive, but one death might be too many. Its use is restricted in many countries, okay? It's not even available in many countries, completely banned. In acute phase, we need to ask ourselves certain questions. Is this patient stable? No, not vomiting, no weak, no loss of consciousness, no hypotension, no confusion, stable, can talk to us. Is this patient unstable? You will understand now, opposite of all what I've just said. Do we require surgery here? Because when there's intestinal perforation, then our medical problem has become surgical problem, where we will need the services of surgeons to help us solve originally medical problem that has now become surgical. Immediate resuscitation needed or not? Is this mild or severe, just like stable or unstable? Are we dealing with drug resistance in this community, in this locality, in this country, in this jurisdiction, or where this patient has traveled to or has emigrated from? Are they battling with drug resistance there? Then, if the patient is unstable, we'll go deeper to then deal with that as a full treatment. You admit first. Check the airways, any secretion, any foreign body, sunshine that is appropriate, make sure the airway is patent. Then the breathing, any central or peripheral cyanosis, respiratory rate, breath sounds, decreased air entry or not, obvious deformity in the chest region, the trachea deviated or not, multi-circulatory system. Our capillary refill right now, any dehydration, what is the blood pressure? What is the heart rate? How about the heart sounds? Do we have IV line? Can we set down 2 of that? So that we'll be able to take sample, give IV fluid. And do we have suitable IV fluid run? Foley catheter to be able to monitor fluid in and out? Vital signs machine hooked up? And of course, do we need blood transfusion here or not? Then, empirical antibiotics with or without dexamethasone. I will tell you when we can give dexamethasone in a bit. Then, the microscopic control and sensitivity test that we've requested for, do we have the result right now? And if that is the case, which specific agent and specific antibiotics are we going to give? Check your antibiotic box for what? For fluoroquinolones, third generation cephalosporins, azithromycin, chloramphenicol, carbapenems if we are dealing with multi-drug resistant strains, and cotrimazole, amoxicillin, and so on. Consider the geographical place where you are and the degree of resistance and susceptibility in your region. Severe cases should warrant intravenous route medications like ciprofloxacin, 400 mg intravenously twice daily for 7 to 10 days. The maximum we can give per day is 1 gram. Let me leave a note here. Children that will likely take ciprofloxacin will take 20 mg per kilogram per day in 2 divided doses for 7 to 10 days. 800 mg per day is the maximum we can go in children, but I'm not even comfortable to give ciprofloxacin to any pregnant woman, any woman that is breastfeeding, and children less than 8 years. Some textbooks or literature will give 10 years. But if we are faced with typhoid and ciprofloxacin is the only available medication that could rescue this child, for this short period of time, I will take that risk. Now, chloramphenicol, like I've gone through how chloramphenicol is not that helpful and so on, but that is what so many people can still afford in poor regions of the world. So, check this dose, like 20 to 25 mg per kilogram intravenously every 6 hours for 14 to 21 days. Then you can go for ceftriaxone, that is third generation cephalosporin, 2 gram intravenously once daily or twice daily for 10 to 14 days. Or if ceftriaxone is to be used in children, just go for 15 to 25 mg per kilogram intravenously every 24 hours for 10 to 14 days. You can go for levotirzine. You can see the dose here, and also in children, what the dose will be. You can pause and check again. If the condition is not severe, meaning the patient is stable, not vomiting, and you are sure that he or she will be taking the medication as now will be prescribed, then we can choose per oral agents. Still, in poor communities, still use chloramphenicol, but we need to explain that they stand the risk of aplastic anemia. Okay, azithromycin could be given as 1 gram start, then 500 milligram once daily or 1 gram once daily for 5 to 7 days. In children, azithromycin could be given at 10 to 20 milligram per kilogram once daily for 5 to 7 days. You can also go through ciprofloxacin, like I've explained earlier. Now, you can use amoxicillin if not sensitive to or allergic to penicillin. You can go for cotrimazole, that is Bactrim or Septra or Septrin, depending on the brand available in your jurisdiction. If there is multi-drug resistance or failure of the previously mentioned drugs, then you may choose from meropenem, imipenem, ertapenem, or doripenem. In shock or coma with severe illness, you can add dexamethasone. Remember the other time I said I will explain further when you can use dexamethasone. Not even only here, even in encephalitis, when the brain is already infected, you can add dexamethasone to your antibiotics at 3 mg per kilogram start, then 1 mg per kilogram every 6 hours times 8 doses. We don't have the luxury of giving dexamethasone for a long period of time. No. You can add the above to chloramphenicol as it is necessary. surgery. Well, we don't pray for this, but sometimes we run to die. If there's peritonitis secondary to intestinal perforation, then you give broad antibacterial coverage and also seek the services of the surgeon to help. Now, the last bus stop when it comes to the treatment of typhoid fever. Fever may persist till 1 week post-treatment. Fever resolves and relapses after 3 weeks with chloramphenicol use. If that is the case, we can change to ceftriaxone. With that, I've come to the end of this short presentation on the treatment of typhoid fever. Please, for you to have full info on typhoid fever, the epidemiology, the diagnosis, the signs and symptoms, the treatment, the vaccines, and the complications and everything, please click on this very link. You'll get that on my channel. Thanks for listening. Remember to share this. Remember to subscribe to my channel. I appreciate it.